Good afternoon, everyone.
On behalf of the Education and Professional Development Committee, I would like to welcome you all to today's webinar entitled 2022 CDC Clinical Practice Guideline for Prescribing Opioids for Pain. And we are thrilled to have Dr. Lisa Yamagishi as our guest who will present. Dr. Lisa Yamagishi received her Doctor of Pharmacy degree at the University of Buffalo School of Pharmacy and Pharmaceutical Sciences in 2017. She completed a postgraduate residency at Duquesne University and St. Barnabas Health, specializing in geriatrics in Pittsburgh, Pennsylvania. Following her postgrad training, Dr. Yamagishi worked as a clinical pharmacist specializing in hospice and palliative care at Delta Care RX. She is currently a clinical pharmacist in Kings County Hospital Center, where she established the Opioid Stewardship program. She has spoken nationally on topics focusing on pain management, opioid safety, and medical marijuana. She is an active member of the American Society of Health Systems Pharmacists, the American College of Clinical Pharmacy, the New York City Society of Health Systems Pharmacists, and New York State Council of Health Systems Pharmacists. Before we get started, I'd like to share some quick points. For those who have technological issues during the presentation, please use the chat option to communicate with the office. Every effort will be made to assist in a resolution. For those who have questions that you would like to direct to the speaker, please use the question box or chat option. And the CE code for the program will be provided at the end of the program. And with that, I'll turn it over to Dr. Yamagishi.
Thank you very much, and thank you very much for having me present today. My name is Lisa Yamagishi, and I'm currently a clinical pharmacist of opioid stewardship at New York City Health and Hospitals at Kings County Hospital Center. So when we first developed the opioid stewardship program at our hospital, we did so in 2019 using the framework that was already in the established antibiotic stewardship program. In that we're a pharmacist-driven program that ensures medication safety and effectiveness throughout our institution that centralizes around opioids through collaborative, a multidisciplinary group of pain management, addictions, behavioral health, social work. And a lot of how we initially built our program in 2019 were from the CDC guidelines in 2016, because there is not much literature on how we're going to build the program. So we basically found ways to identify high-risk patients, offer naloxone counseling, and a lot of the metrics that we use in our institution were from the 2016 guidelines. And since 2019 up until today, there's been many evolutions in what we first built our program on in 2016, because there are certain nuances in being able to ensure safety as well as optimize patient care. So as I'm really excited to present this new guideline, because it does address a lot of the things, a lot of the nuances that we picked up on as well. So without further ado. So it's just a slide to say that in this activity, I have no conflict of interest to report. So here are the objectives. We are going to describe the current state of the opioid epidemic in the United States, review recommendations from the 2016 CDC opioid prescribing guidelines. We're going to evaluate the impact of opioid prescribing practices that resulted from the previous guidelines. And we're going to summarize key changes in the updated 2022 CDC prescribing guidelines. And here are some key abbreviations that I'll be using in my presentation. So before we go over the current opioid epidemic, I have a polling question here. Which of the following statements regarding the opioid overdose death rates in the United States is true? A, overall opioid overdose death rates have declined since the 2016 CDC guidelines for prescribing opioids for chronic pain. B, overall opioid overdose death rate has remained steady since the 2016 CDC guideline for prescribing opioids for chronic pain. C, prescription opioids account for 90% of all opioid overdose deaths. Or D, synthetic opioids account for 90% of all opioid overdose deaths. Okay, and we have here that most people said that D, synthetic opioids account for 90% of all opioid overdose deaths, and that is correct. So here's an illustration of the opioid epidemic. And as we all are familiar with, it really started in the 90s when prescription drug companies started promoting certain opioid formulations, such as extended release opioid formulations, where they said that opioids really can't be addictive if they are being truly treated for pain. And this really ramped up prescription drug sales, and pain was promoted as a fifth vital sign, where all patients need to be assessed and treated for pain and optimized regimens. So fast forward to 1999 and the beginning of 2000s, when we first started seeing a rise in prescription overdose deaths. Wave number two is around 2010, when we started seeing heroin overdose deaths. And wave number three, 2013, is when we first started seeing synthetic overdose death rates. When I first started this presentation, when I first presented this, I presented on 2016 CDC guidelines. And this graph looked a lot different back then, where we started seeing an acceleration in overall overdose death rates. And it was pretty much even among prescribed opioids, heroin, and synthetic opioids. So since then, we've seen that the prescription opioids have kind of plateaued, and heroin has been kind of plateauing and slowly declining. However, we see here that like synthetic opioids are predominantly coming from China. And since around 2019, they placed a lot of restrictions of the fentanyl coming from China and precursors coming from there as well. However, we see that there's been increase in like other places where they may be coming from, such as India, and a lot of it's being produced in Mexico from drug cartel. And you combine that with not only it being produced in our hemisphere, but we have the pandemic that happened in 2020, where it just really ramped up a lot of the illicit drug use. So fast forward to 2020, where we see here that synthetic opioids actually account for 90% of all overdose deaths. We see this data here in prescription overdose deaths as well. The blue bar being all prescription overdose deaths. The yellow bar on the top bar, the yellow one, is we see here at 2016, ever since the CDC guidelines, it actually went down of overdose deaths from prescription opioids alone. The red bar below are prescription opioids in combination with synthetic opioids. Now, this may be a patient's on prescription opioids, or they may be getting some counterfeit pills that happen to be laced with fentanyl. So we see here that in 2020, it actually surpassed overdose deaths that exclusively occurred from prescription opioids. And we also look at this data of fentanyl overdose deaths, where we see here that in the beginning, it was predominantly in the Northeast region of the country. But again, since the fentanyl is coming, from within this hemisphere, and it's really just been ramping up throughout the entire country. So let's go over the 2016 guideline for prescribing opioids for chronic pain. And here's the cover. So when they first made these guidelines, they had three purposes. They wanted to improve communication between clinicians and patients about the risks and benefits of opioid therapy for chronic pain. They wanted to improve the safety and effectiveness of pain treatment, and they wanted to reduce the risks associated with long-term opioid therapy. And this includes opioid use disorder, overdose, and death. And when they made these guidelines, they were exclusively meant for patients with chronic pain. That's pain that persists longer than 3 months or past the time of normal tissue healing, and excludes patients with active cancer, patients with palliative care, and patients with end-of-life care. And when they made these guidelines, they had 5 primary clinical questions that they wanted to answer. They wanted to address the effectiveness of long-term opioid therapy, the risks of harms associated with opioids, opioid dosing strategies, risk assessment and mitigation, and the effects of opioid therapy for acute pain on long-term use. And the 12 recommendations that they made were in 3 categories, and a lot of these categories are going to be similar to the new guidelines. So they want to determine when to initiate or continue opioids for chronic pain, opioid selection, duration, dosage, follow-up, and discontinuation, and assessing risk and addressing harms for opioid use. So number 1, always non-pharmacologic therapy and non-opioid pharmacologic therapy are always first line. And opioids, if they are to be started, should be combined with these non-pharmacologic and non-opioid therapies. 2, they want to establish realistic treatment goals before starting therapy, including realistic goals for pain and function, and how therapy will be discontinued if benefits do not outweigh the risks. So they do highlight that. They said that clinically meaningful improvement for patients is 30% reduction in pain scores or functional 30% increase in function. And always before starting therapy, they highlighted that clinicians should always have an exit plan of how to discontinue the opioids. Number 3, before starting and periodically during therapy, clinicians should discuss with patients known risks and benefits of opioid therapy. Number 4, when starting opioids, use immediate release opioids instead of extended release long-acting opioids. And they do use the FDA definition of opioid tolerant. That's patients that are around over 60 morphine milligram equivalents per day for 7 days and or longer. And that's something that we use in our institution as well, as far as when to start patients on extended release opioids. Number 5, and this is really important, they stated to start at the lowest effective dose, carefully reassess evidence of individual benefits and risks when increasing dosages to above 50 morphine milligram equivalents per day, and to avoid increasing dosages to over 90 or carefully justify decision to titrate dosages to over 90. And again, when we first established our program, these are the metrics that we chose to report quarterly of these dose ranges of under 50, 50 to 90, and over 90 for really high risk patients. Number 6, prescribe no greater quantity than needed for the expected duration of pain severe enough to require opioids. 3 days or less would often be sufficient, and over 7 days will rarely be needed. So this may sound familiar to a lot of us in New York State, where right after these guidelines, 2016, when these guidelines were released, 2016 was that time when New York State passed a law where for clinicians that are prescribing opioids for acute pain should not prescribe longer than a 7-day fill for these opioid regimens. Number 7, evaluate benefits harms 1 to 4 weeks before starting opioid therapy or dose escalation. Evaluate continued therapy every 3 months. If benefits do not outweigh harms of continued therapy, optimize other therapies and or taper, discontinue opioids. Number 8, before starting and periodically during continuation, evaluate risk factors for opioid-related harms. Offer naloxone to patients at risk of overdose, history of overdose, history of substance use disorder, higher opioid dosages, and concurrent benzodiazepines. And this is something that we use in our institution when we offer naloxone to patients at discharge. And this may sound familiar to us in New York State as well. I think June of this year, past year, is when New York State passed a law that clinicians should prescribe naloxone for any patient that has these risk factors. And I think they use over 90 morphine milligram equivalents. So when they're prescribing opioids, they need to prescribe naloxone along with that prescription. Number 9, review history of controlled substance prescriptions, PDMP data, every prescription to every 3 months. Use urine drug testing before starting opioid therapy at least annually. Avoid prescribing opioid pain medications with benzodiazepines concurrently, and offer arrange evidence-based treatment for patients with opioid use disorder. And this includes methadone or buprenorphine, and it always has to be in combination with behavioral therapy. So just a brief overview on morphine milligram equivalents and how to calculate that. So morphine milligram equivalents is the amount of equivalent dose to oral morphine that a patient will get. So what you do is you take a patient's opioid, their dose, and you multiply it by however many times they receive that dose in a day, and then you multiply it by a conversion factor. And with that, you round down 25 to 50% to account for incomplete cross tolerance. So here's a table that the CDC released. We use a table published by Marilyn McPherson through Demystifying Opioid Dose Conversions that was published through ASHP. So say, for instance, a patient's on oxycodone 5 milligrams every 4 hours around the clock. So that patient would take 30 milligrams of oxycodone in a day. And the conversion factor we see here is 1.5. So 30 times 1.5 is, we calculate 45 morphine milligram equivalents per day. And of course, round down 25 to 50% if you're going to switch the patient over to another analgesic. So just to recap, some recommendations. Number 5 was to carefully reassess evidence of individual benefits and risks when considering increasing dosages to over 50 morphine milligram equivalents per day, and to avoid increasing dosages to over 90. And if patients don't increase improvement in pain and function at over 90, or if there's escalating dosage requirements, clinicians should discuss other approaches to pain management and to consider tapering opioids to a lower dose, or to taper and ultimately discontinue opioids. So let's view what happened from 2016 to today. So as far as public, regulatory, and third-party policy changes from 2016 to 2018, there were 527 federal and state opioid-related policies, statutes, rules, regulations, and guidelines. 170 of the policies imposed limits on opioid prescribing. 35 of policies mentioned integrated the 2016 CDC opioid prescribing guidelines, and 34 policies actually limited the use of opioids, even for patients with cancer or chronic pain. So we already went over a lot of New York State, as far as like the opioid prescribing for acute pain and the days limit, duration limit on that, as well as the new naloxone prescribing. Here's an example of a letter that went out from the New York State Department of Health to prescribers. And this actually cites the 2016 CDC guidelines, where excluding patients with cancer, patients under hospice or palliative care, that if a patient has pain for over 3 months or beyond normal tissue healing, that the clinicians have to document pain management or functional improvement in the patient's chart, and that they should have a goal to taper or lower dosages, or taper and discontinue opioid therapy to follow the 2016 CDC guidelines. So let's take a look at opioid prescribing practices in the United States before and after the CDC guidelines. So Boner et al. Conducted an interrupted time series analysis of monthly opioid prescribing from 2012 up until 2017. And what we see here is that there's been, the top graph right there is overall prescribing rates of opioids, and it's actually declined steadily from 2012 up until 2016. And what we see here is after 2016, it's declined even more. I guess the rate of deprescribing accelerated, right? The bottom graph right there is number of opioids dispensed with total daily dosage of over 90 morphine milligram equivalents per day, and that's the really high risk patients, right? So we see a decline since 2012 to 2016, but from 2016 onward, the slope has significantly increased, right? So, and we also see here as far as rates of non-opioid pen medication prescribing after the release of the 2016 guidelines. So Goldstick et al. Conducted a cohort study using claims data from 2011 to 2018. And the blue line right there is opioid prescribing rates, and declined up until 2016. And the rate of deprescribing opioids has I guess, decrease further. Non-opioid analgesic use has remained steady from 2012 up until 2016, and non-opioid analgesic use has increased since the release of the guidelines. And there's been a largest change among patients with chronic pain. For opioid tapering among patients prescribed long-term opioid therapy, Benton et al. Conducted a cohort study for 100,000 patients that were prescribed over 50 morphine milligram equivalents per day for over a year. And what they found that patients were being tapered opioid doses, and the rate of tapering increased from 10.5 to 13.7 in 2000, and from 16.2 in 2016, 22.4% in 2017. And you see here on the right-hand side, that if patients on a higher dose, say over 300 morphine milligram equivalents per day, though there's a higher proportion of those patients that are being tapered opioids. So in 2016, we see here that 30% of those patients were tapered opioids. And in 2017, 42% of those patients were being tapered opioids. So the higher the dose, more likely those patients were being tapered. 18.8% of patients had a maximum tapering rate of over 40% per month. So the CDC, when they recommended tapering patients, they recommended like the starting point is 10% per week. And you can go up from there. You can go from 10 to 50%. If a patient has been on a long-term higher dose opioid regimen, you can possibly consider tapering at a slower rate of even 10% per month. So what we see here is 20% of patients had a higher tapering rate than what is typically recommended for these patients. So the American Academy of Pain Medicine formed a multidisciplinary group in 2016 to review the CDC guidelines. And while they agreed with the majority of how to ensure safety among opioid prescribing practices, they found some issues that they felt need to be addressed, and they published their findings in Pain Medicine in 2019. They felt that there was a confusion in practice on the daily opioid dose ceilings. There were hard limits on dose ceilings that may result in abrupt dose reductions. And this in turn will lead to withdrawal, hyperalgesia, and self-medication. And dose ceilings were set as policy when payers make coverage and reimbursement decisions. There were unknown consequences of abrupt versus gradual tapers. There were a lack of resources towards integrated, multimodal, and comprehensive pain care, and naloxone co-prescribing was being underutilized. Fast forward to, I think, 2 months after the American Academy of Pain Medicine released their findings, the FDA actually released a drug safety announcement. And they found reports of serious harm that was done onto patients that were dependent on opioids. And they were forced into a rapid dose decrease and discontinuation. So they sent a notice and advised clinicians to not abruptly discontinue opioids in patients that are physically dependent. And they also sent an advisory to patients that if they are dependent on opioids, to not self-discontinue or taper, and to always seek a clinician help in being able to slowly taper. Fast forward a few more months later, the original CDC guideline authors actually published a perspective in the New England Journal of Medicine to clarify the flaws that were identified. And they said the guidelines improve patient outcomes when they lead to policies that reduce harm. And quote, some policies and practices purportedly derived from the guideline have in fact been inconsistent with and often go beyond its recommendations. And the original CDC authors outlined the unintended consequences of the 2016 guidelines, where there were hard limits on dosing and forced abrupt discontinuation and tapering. And that some policies that have been released affected patients with pain that have been associated with cancer, pain from painful surgical procedures, and also affected patients with sickle cell disease. Dosing, there's been inflexible application of recommended dosages, inflexible duration, again, the 3 to 7 days, opioid agonist for opioid use disorder. So that's something that is highlighted that we had to change in our opioid stewardship program. We recognize that in our metrics for morphine milligram equivalents per day, methadone and buprenorphine have a high conversion. Say, for instance, you have a patient that's on 120 milligrams of methadone. That could be thousands of morphine milligram equivalents. And it was definitely skewing our numbers as far as, ensuring safety, where you want to promote the use of these medications to really prevent illicit drug use in the community and really provide them with resources to be able to provide medication assisted therapy. So we decided to exclude methadone and buprenorphine from our metrics because, again, that skews the morphine milligram equivalent numbers. So patient care, referral dismissal of patients on high doses because clinicians were afraid of repercussions, and some clinicians stopped prescribing opioids entirely. As far as long-term risks after opioid dose tapering, Fenton et al. Conducted a cohort study of 30,000 patients that underwent opioid tapering from 2008 to 2017 after over 12 months of over 50 morphine milligram equivalents per day. And what they found was, compared to pre-taper, patients that experienced an induction of tapering experience higher incidence of overdose or withdrawal, overdose, or acute mental health crises. And these risks persisted for up to 2 years after taper. Now, will discontinuing or tapering opioids lead to illicit drug use? There's actually not many studies that have been done on it, but the CDC did cite this one observational study that was done on 23,000 patients that were prescribed opioids. And what they found that patients whose opioids were discontinued were 2 times likely to have heroin use than patients that have not been discontinued opioids. So they estimate 20% of patients who use heroin after opioids were tapered, discontinued opioids prior to illicit use. So, but again, more studies do need to be conducted on this if there's direct correlation. So let's review some changes in the updated 2022 CDC opioid prescribing guideline. And here's the cover. So Christopher M. Jones, who is a pharmacist and is the acting director of the CDC National Center for Injury Prevention and Control, stated that patients with pain should receive compassionate, safe, and effective pain care. We want clinicians and patients to have the information they need to weigh the benefits of different approaches to pain care with the goal of helping patients reduce their pain and improve their quality of life. So the guideline purpose, similar to the 2016 guidelines, they did add that its purpose is to mitigate pain and to improve function and quality of life with patients, for patients with pain. And they also added 5 guiding principles for implementing these recommendations. Number 1, acute, subacute, and chronic pain needs to be appropriately assessed and treated independent of whether opioids are part of their treatment regimen. Recommendations are voluntary and are intended to support, not supplant, individualized patient-centered care. Flexibility to meet the care needs and the clinical circumstances of a specific patient is paramount. A multimodal and multidisciplinary approach in pain management, attending to the physical health, behavioral health, long-term services, and supports an expected health outcome and well-being of each person is critical. Number 4, special attention should be given to avoid misapplying this clinical practice guideline beyond its intended use or implementing policies purportedly derived from it that might lead to unintended and potentially harmful consequences in patients. And number 5, clinicians, practices, health systems, and payers should visually attend health inequities, provide culturally and linguistically appropriate communication, including communication that is accessible to persons with disabilities, and ensure access to appropriate, affordable, diversified, coordinated, and effective non-pharmacologic and pharmacologic pain management regimens for all persons. So they change the scope of patients that are included in the 2022 guidelines. So this doesn't just include patients with chronic pain, it also addresses acute pain, that's pain that persisted for less than 1 month, as well as subacute pain, pain that's persisted 1 to 3 months. And I'm actually really happy that they excluded sickle cell disease pain in these guidelines, and they also exclude cancer pain and palliative care and end-of-life care. The scope of audience has changed. The 2016 guidelines was primarily for primary care clinicians. Now they expanded the scope to outpatient clinicians, as well as team members. And this will include behavioral health specialists, social workers, psychologists, as well as pharmacists and registered nurses. What also is new is how they addressed health equity and disparities in treatment of pain. So it's widely known that there are disparities in pain treatment. Black patients actually have been under-prescribed and under-assessed for pain, and they also have faced a lot of the scrutiny and the repercussions of these policies of, say, for instance, a patient may have some aberrant behavior. Black patients are more likely to have regular visits with clinicians and abrupt discontinuations compared to white patients. Asian, Hispanic, and Black patients postpartum are assessed for pain less than white patients postpartum. So the 2022 clinical practice guideline describes evidence of long-standing health disparities that exist in the treatment of pain, such as geographic disparities and disparities in treatment due to access and affordability, and addresses the health inequities related to race and ethnicities, as well as guiding principles for implementation. So for acute pain, that's pain of a duration of less than 1 month, non-opioid therapies are at least as effective as opioids for many common acute pain conditions. And the conditions are listed right there. So there are many guidelines that have been released, such as the ALTO guideline, which is an alternative to opioids guideline that's implemented in many emergency departments in the country, where they actually list common pain that you see in an acute setting and non-opioid first line approaches to treat each specific pain. So it's actually really exciting that the CDC included recommended regimens for acute pain. Now, opioid therapy has an important role for severe acute pain. That's patients with severe traumatic injuries, including crush injuries and burns, invasive surgeries typically associated with moderate to severe post-operative pain, as well as other severe acute pain where NSAIDs and other therapies are contraindicated or likely to be ineffective. And always prescribe immediate release opioids at the lowest effective dose, no longer than the expected duration of pain severe enough to require opioids. So I did highlight that because what we see here is they completely took away the less than 3 days is normally adequate, more than 7 days is rarely needed. So they completely took that out, and it's case-by-case basis. Opioids should only be used as needed, not scheduled, and encourage and recommend an opioid taper if opioids are taken around the clock for more than a few days. For subacute pain, for pain that persists for 1 to 3 months, that a clinician should reassess a patient's prescription to ensure that opioid prescribing for acute pain does not unintentionally become long-term opioid therapy, and ensure potentially reversible causes of chronic pain. They also differentiated between when to initiate opioid therapy and how to initiate opioid therapy, as well as how to continue opioid therapy. And what we see here is in these recommendations, they completely take out how to discontinue opioid therapy in both of these scenarios and when to taper. They actually did that because they had a whole separate section on how to taper. So what we see here for initiating therapy, they really focus on non-opioid and non-pharmacologic therapies and how to select opioids and how to determine the dose. For when you're continuing opioid therapy, they really go into detail of how to follow up with a person's pain, how to, when to increase the dose, and how long that duration should be. So again, there was clarification that the recommendation on dosages are not intended to be as an inflexible, rigid standard of care, and they're intended to be guideposts to help inform clinician-patient decision-making. And the recommendations are based on starting or increasing doses. And again, separate recommendations on how to taper and discontinue. So what we see here, as far as opioid dosing is concerned, the 2016 guidelines, again, highlights the over 50 morphine milligram equivalents per day and to avoid increasing the dosages to over 90 and carefully justify, document a decision of whether or not a patient should continue over 90 morphine milligram equivalents per day. And the 2022 guidelines completely removed that. So again, you know, just really like a patient-centered, tailored approach for every pain patient to carefully evaluate individual benefits and risks when considering increasing dosages and to avoid increasing dosages above levels likely to yield diminishing returns and benefits relative to the risks of each patient. Now, as far as morphine milligram equivalents, they do recommend a typical starting dose for an opioid naive patients, where a typical PRN dose is 5 to 10 morphine milligram equivalents. And this is something that we instated in our institution as well, where we provided what the conversion would be of a typical starting dose in an opioid naive patient. And daily dose should typically not exceed 20 to 30 morphine milligram equivalents per day, and to pause, reassess at over 50 morphine milligram equivalents per day. And again, case by case scenario. So for opioid tapering, the previous 2016 guidelines, while they included opioid tapering in each of their recommendations, they didn't really go into great depth on how to taper each patient, just that it's recommended. And the ultimate goal is to discontinue each regimen. So here they actually created a separate section on how to determine whether, when, and how to taper opioids, and how to provide advice to patients prior to tapering, pain management during tapering, behavioral health support during tapering, the tapering rate, managing how to manage a patient's with opioid withdrawal during tapering, challenges to tapering, and continuing high dosages of opioids. So from 2016 guidelines, again, while they recommended it a lot, there was really like scant evidence on what is the most effective strategy. It's actually more in their rationale section where you have to delve deep to see what each of the studies recommended. And from that, they said a good starting point is 10% per week. And from there, you can reduce by 10 to 50% per week, depending on how the patient tolerates that initial 10% per week taper. And the rapid taper over 2 to 3 weeks is recommended in cases of overdose. And patients that have been taking opioids for years, that slower tapering of maybe slower than 10% per week may be warranted, such as 10% per month, and that a tapering is successful as a patient progresses. So the new guidelines actually start off with these patients that have been taking opioids for 1 year or longer. So they say to reduce by 10% per month or slower. For patients that have been taking opioids for weeks to months, you can possibly start at 10% of the original dose per week or slower until 30% of the original dose is reached, then by 10% of the remaining dose weekly. And that a rapid taper discontinuation only recommended in cases of overdose and should be avoided. And the goals of the taper vary depending on the patient. So previously, tapering goal was, can the patient maintain a consistent taper and eventually discontinue the opioids? Now, the goals are just going to vary depending on the patient. So they go into great depth of the non-opioid therapies for each of the pain conditions, each of the acute and chronic pain conditions. non-opioid pharmacologic therapies are NSAIDs, that's topical or oral, acetaminophen, tricyclic antidepressants, SNRIs, anticonvulsants, just pregabalin, gabapentin, anacarbol, oxcarbazepine, and capsaicin and lidocaine patches. Non-pharmacologic therapies include ice, heat, elevation, rest, and immobilization and or exercise. So for acute back pain, typical non-opioid therapies include NSAIDs, and they found that they have been similarly effective to opioids, and skeletal muscle relaxants can be considered. There's insufficient evidence as far as effectiveness on opioids for acute back pain. For acute musculoskeletal pain, they recommend first-line topical NSAIDs, and after that, you can consider menthol gel, oral NSAIDs, or oral acetaminophen. For acute episodic migraine, you can consider triptans, NSAIDs, antiemetics, ergots, acetaminophen, CGRP antagonists, and lamicidin, and opioids are not recommended. For chronic back pain, they recommend NSAIDs and duloxetine. Fibromyalgia, FDA-approved drugs include duloxetine, milnacipran, and pregabalin, and benefits of initiating opioids are unlikely to outweigh risks. For chronic pain for osteoarthritis, acetaminophen is no longer first line in treating osteoarthritis. Topical and oral NSAIDs are preferred, topical for smaller joints affected. Celecoxib, COX-2 inhibitors are especially recommended for pain that persists for over 1 to 3 months, have been shown to be very effective. And duloxetine has been shown to be effective, especially among patients that are over the age of 65. For chronic neuropathic pain, tricyclic antidepressants, SNRIs, anticonvulsants such as pregabalin, gabapentin, anacarbol, oxcarbazepine. And there's limited evidence on the efficacy of capsaicin and lidocaine patches. FDA-approved drugs for diabetic neuropathy include duloxetine and pregabalin, and post-herpetic neuralgia, FDA-approved drugs are gabapentin and pregabalin. So I have a polling question right here. In patients with opioid use disorder, clinicians should A, offer arranged medication-assisted therapy with buprenorphine or methadone with or without behavioral therapies. B, offer arranged medication-assisted therapy with buprenorphine or methadone in combination with behavioral therapies to increase retention during medication-assisted therapy. C, offer arranged medication-assisted therapy with buprenorphine or methadone in combination with behavioral therapies to increase compliance with opioid detoxification. Or D, offer arranged detoxification without medication-assisted therapy in a clinically monitored setting with trained specialists. Okay, let's see what we have here. So letter C is number one answer. That was offer arranged medication-assisted therapy with buprenorphine or methadone in combination with behavioral therapies to increase compliance with opioid detoxification. And number 2 was to increase retention during medication-assisted therapy. It's actually wrong. It's letter A, to offer arranged medication-assisted therapy with buprenorphine or methadone with or without behavioral therapies. In patients with opioid use disorder, clinicians should not A, offer arranged treatment with buprenorphine, B, offer arranged treatment with buprenorphine with naloxone, C, offer arranged treatment with methadone, D, offer arranged treatment with oral naltrexone. Yes, the correct answer is letter D, where they do not recommend treating a patient with oral naltrexone. So there are changes as far as how to treat patients with opioid use disorder. All clinicians should, after determining a patient has opioid use disorder based on the DSM-5 criteria, they should offer medication-assisted therapy. And this will include buprenorphine, methadone, or naltrexone long-acting injection. They used to recommend oral naltrexone, but in the new guidelines, they said not to use oral since they found that it has not been effective. So updates. Behavioral therapy should not preclude delay medication-assisted therapy. Now, previous 2016 guidelines stated that offering the behavioral therapy along with the medication-assisted therapy increases retention and increases the rate of being able to taper and discontinue with buprenorphine. However, what they found were that patients that attended weekly meetings with a group, consistently went to rehab counseling and had a really intensive behavioral health interventions, compared to a patient that was offered a medication-assisted therapy with like just an informational pamphlet, that both had similar outcomes as far as being able to prevent a patient from using illicit opioids. So they found that, if a patient were to reject going to rehab, that it shouldn't preclude them from being able to access methadone or buprenorphine. Detox without medication-assisted therapy is not recommended and increases the risk of resuming drug use, overdose, and death. Now, previous 2016 guidelines said that, again, buprenorphine can be used for retaining patients or detoxing. Now they don't recommend detoxing. They don't really use the word detoxing in general in the 2022 guidelines. So, opioid dosing thresholds are not applicable to medication-assisted therapy. And again, this is something that we adapted to in our opioid stewardship program, where we exclude methadone and buprenorphine use in our morphine milligram equivalents used in the hospital. No recommended duration limit with medication-assisted therapy. Discontinuation is associated with risks for return to drug use and overdose. And this is something that I talk with my patients a lot, where they'll tell me, hey, doc, I'm on methadone, but I swear, I'm going to get off of it. Or, I interviewed them about substance use disorder. And they say, well, I'm thinking about starting Suboxone, but I probably won't be on it for long. And I always tell them, listen, there is no shame in being on this maintenance regimen. I've met people that have been on methadone since the 20s. And there's no shame in that. And that I'm just glad that they're continuing the regimen. And they found that patients in guidelines, when they try to recommend like a tapering schedule or a tapering regimen, they found that if you ever set any kind of a guideline and clinicians attempt to follow it, there's just an increased risk of like a patient, using illicit drugs. It's always failed. So it's always a patient-centered approach on whether or not they really want to taper. And a goal of like discontinuing and detoxing is not really a goal per se. So again, no recommendation duration limit. Updated goal is to reduce the risk of overdose and death. So that's the ultimate goal. That's the only goal. The goal isn't to keep them on a program. The goal isn't to detox them. The goal is just to reduce the risk of death. Now, there is an important update as far as opioid use disorder and pain management. This is something that we see in our hospital a lot, and there's a lot of fear in being able to treat these patients adequately, especially with acute pain. So it's good that CDC actually provided recommendations here based on the actual practice guidelines by ASAM. So patients with active opioid use disorder but are not in treatment, you can consider adding small doses of buprenorphine or small doses of methadone. And this will have a twofold approach where the analgesic effects of methadone are 6 to 8 hours after administration. And it can also, because of its long half-life, reduce the risk of withdrawal as well. And it's very potent analgesic. And the same goes for buprenorphine as well. All patients should be on non-opioid medications, have behavioral approaches, physical therapy, and procedural approaches such as regional anesthesia. For patients already on medication-assisted therapy methadone, if they're in an acute pain, you can temporarily split the dose 3 times a day, 4 times a day. So this is something that was like anecdotally, like, you know, recommended by like pain management people, specialists, but now the CDC makes a firmer recommendation on this. For patients that are refractory, moderate, severe pain, you can consider adding a short-acting full opioid agonist. And these patients typically will require higher doses of any breakthrough medication because they're high tolerance. And for patients on medication-assisted therapy with buprenorphine, you can split that dose 3 times daily or 4 times daily as well. For patients refractory with that, with moderate severe pain, you can consider adding buprenorphine PRN. So this is because of the strong affinity to the mu receptor as a partial mu agonist. They may not be able to experience the full benefits of a short-acting opioid, so they recommend actually adding another buprenorphine PRN. You can consider adding a short-acting full opioid agonist in specifically a monitored setting, because again, these patients will typically require very high doses of breakthrough regimen. So just because a patient's on medication-assisted therapy doesn't mean that they can't be adequately treated for pain, especially like in a surgical setting. So a lot of a lot of healthcare settings do actually include how to treat patients with medication-assisted therapy in a surgical setting. And the notion used to be to discontinue the buprenorphine prior to a procedure. So patients will potentially, you know, if they go for a painful procedure, that they will be able to benefit from the analgesia that's given perioperatively. That has since been fallen out of favor, since the risk of withdrawal up to the surgery will outweigh any benefits from the analgesia they are to receive. So a lot of clinicians will recommend continuing the buprenorphine up until surgery, and possibly if the pain is refractory, you can split that dose of buprenorphine. So patients on naltrexone, non-opioid analgesic, is first line, and patients that are refractory with moderate to severe pain, you can consider adding a high potency NSAID such as ketorolac. And because they have that long-acting naltrexone injection in their system, unfortunately, there's no way to really reverse it. So they might not be able to benefit from opioid analgesics. And much like buprenorphine, because of that, if you are to give opioids, it's typically going to be a very, very high dose. So it should only be reserved in a very monitored setting. So from the Omnibus Bill of 2023, as of June of this year, X waiver is no longer needed for buprenorphine. So it's really important, since this removes the barrier of patients being able to have access to a potentially life-saving medication. So that being said, clinicians should be very familiar on how to dose patients with opioid use disorder, and how to treat pain in these patients as well, and how the different indications will warrant different dosing strategies. So in summary, the new CDC clinical practice guideline for prescribing opioids for pain emphasizes the goal to advance pain, function, and quality of life while reducing misuse, diversion, and consequences of prescription misuse. Opioids should not be first-line treatment for pain. Recommendations should not replace clinical judgment, and clinicians should provide individualized care to patients to properly treat pain. And here are my references.
Thank you so much. Thank you so much, Dr. Yamagishi, for that wonderful talk. We do have one question in the chat so far, and if anyone has any other questions, you can direct them to either the Q&A or the chat box. So the first question that I have is from Nicole is, what are your thoughts on tramadol as a drug? Just as bad as other opioids, or is it too variable in response due to polymorphisms, or any other thoughts that you might have?
I'm tramadol, like, as far as like the safety of tramadol, I mean, there's no opioid is truly a safe opioid, right? But as far as the conversion, it's smaller conversion. I think like the 25 milligrams, well, 150 milligrams might, no, I'm sorry, I'm had to do quick math in my head. 125 milligrams of tramadol, maybe like 25 milligrams of opioid. I know it's like a 4-to-1 conversion, but I know it also has like serotonergic properties that can be benefit patients with pain, and and a lot of pain regimens, opioid sparing pain regimens, typically when you are using opioids in a post-operative setting, they do recommend tramadol as first line. Now, as far as like efficacy is concerned, because it's like less potent, it may not be effective for like severe acute pain. But as far as like treating like refractory pain for like chronic conditions, it's proven to be effective, especially in like chronic pain, chronic back pain. So it really depends on case by case scenario. The evidence is pretty good on it, but it's not very potent for like severe acute pain.
Okay, and there is one more question in the chat that I think we have time for, and it is, was there an additional comment on the use of celecoxib as a non-opioid choice for pain management?
Yeah, so I think I briefly went over how celecoxib is recommended for specifically in the CDC guidelines. They recommended it for, I think it was chronic osteoarthritic pain. And there's a lot of evidence as far as like COX-2 inhibitors being very effective and safer than typical NSAID. And that's something that is that we've are enforcing in our institution as well, of promoting the use of celecoxib even in the perioperative setting for opioid sparing strategies. So absolutely, and yeah, especially for among geriatric patients, it's safer.
Okay, well, thank you again, Dr. Yamagishi. I don't see any other questions in the chat so far. So thank you again for giving today's webinar. With that, I will launch into giving the CE codes.